All right, we are back. This is Senate Health and Welfare, and we're continuing a discussion on mental health issues. We are now looking at S-194 and 195. And we have with us today Wilda White. Wilda, why don't you introduce yourself for the record, and we'd like to hear your testimony.
Thank you, Senator Lyons. Good morning, committee. My name is Wilda White, and I am the founder of an organization called Mad Freedom, which is a human and civil rights advocacy organization dedicated to the mission of securing power and influence to end the discrimination against people based on their perceived mental state or mental illness. I am also an attorney and spent a lot of my career as a businesswoman, both running businesses and counseling CEOs and senior managers of Fortune 50 companies. I also was the inaugural chairperson of the Mental Health Crisis Response Commission here in Vermont. I was the executive director of Vermont Psychiatric Survivors. And I'm here this morning with a team who are together bringing this legislation for your consideration. And that team includes people you see on the screen here, Hillary Melton, the executive director of Pathways Vermont, Gloria Vandenberg, the executive director of Alyssum, which is a peer respite, Ken Russell, the executive director of Another Way Community Center in Montpelier, and Kareem Chapman, who is the executive director of Vermont Psychiatric Survivors. What I'd like to do with the time I have is give you a little bit of background about this bill, answer some of the questions that came up during the walkthrough, and then turn it over to some of the witnesses to provide more of the details of what these bills would do. These bills are the culmination of decades of experience by peer-led organizations in providing both peer support, peer respites, and community centers. They're also supported by rigorous analysis, both in a white paper that this team authored, which I have submitted to the record, and also a research report that looked at peer certification programs throughout the United States and Canada, and what were the leading practices in implementing those programs. So this is not something that we dreamed up overnight. This is really the result of a lot of work, pilot programs, if you will. I know some of you mentioned that perhaps this should be done as a pilot. I want to assure you that Alyssum is that pilot program that's been operating for 10 years. And because of the success of that program, we brought this bill because we want to roll that out throughout the state, because Alyssum is oversubscribed with a long waiting list, a really unprecedented occupancy rate. We also have 2 existing community centers in the state, also providing the pilot programs that some of you thought we should have. We have Another Way in Montpelier and Pathways Vermont in Burlington. And we also have been providing peer support that has been funded by the Department of Mental Health in the state for many years now, but without the benefit of training standards, competency standards, or a credential, and without the benefit of qualifying for reimbursement through Medicaid, which reduces the state's obligation. For example, Medicaid pays like $1.68 for every $1 that Vermont pays, leading to a gross of $2.68. So I think this bill is intended to actually increase the size of the pie that we'll have available to fund mental health services, rather than just reshuffling and redivvying up that pie. So one of the things that people asked in the last meeting was, what is the name of the credential? Well, the bill proposes that credential be a mental health peer support specialist credential, or a family-to-family peer support specialist credential. There are also questions about what I will call the grandfather clause, because there are people currently providing peer support in the state. And so there were some questions about, like, what happens to them? Well, the bill proposes that those people who are currently providing peer support as of December 31st of this year, they would be required to take a mini written test, and then they would become certified they would have that same credential that I just talked about. They wouldn't just automatically be grandfathered in without figuring out whether they met any standards. Our group talked long and hard about this, and some states do that. Some states say, hey, if you were doing this before this bill, you just walk right in and we'll give you a credential. Our group felt, no, we don't want to do it that way. We should make sure they know something. And so, but we thought a good compromise was not having to go through all the training and taking the long test, but passing a basic competency exam that would be developed in the course of developing the credential. Others ask where peers work. Peers work everywhere. They work in prisons, they work in hospitals, they work in emergency departments, they work in people's homes, they work in peer respite, they work in educational institutions, they work in mobile crisis support. So the places that they work are limitless. It's where people are, and people are who are maybe in some kind of distress. There's another question about, do other states, are there certification programs designed exactly as this bill proposes, or are there other identical states? I will say at the outset that states design their own programs. Many design their programs like the one we have designed here. So what we've done is we've divided a peer certification program into 3 buckets. One, we say, is developing the program. And a peer-run entity would respond to a request for a proposal from the Department of Mental Health to say, yes, we will help you develop this program along the lines that are laid out in the statute. And then once the program is developed, there's 2 other buckets of tasks that need to be done to operate the program. That first bucket is screening people who apply for the training and then training them. So that would be another request for a proposal for an entity that would do that screening and training. Then the third bucket is people who would administer a test once people have been trained, and if they've passed the test, then make sure they sign the code of conduct and then certify them. And then you'd have to keep track of continuing education requirements, which is required for Medicaid reimbursement. And you'd also have to, if there were complaints that someone had violated the scope of their practice or the code of ethics, then you'd have to investigate and make a decision about revocation. So those are the 3 buckets. Some states have the way they design their program, peers lead all of those buckets. Some states, it's led by the Department of Mental Health. In some states, it's led by their Office of Professional Responsibility. And in some states, they actually contract with a consortium called ICNRC, and they work through that consortium. Medicaid allows states to design their own programs. It has a lot of flexibility. We elected this path because based on a General Accounting Office study of certification programs in 8 major states, they identified as a leading practice the involvement of peers in the development and operation of peer certified programs. And that's the very reason why we don't think it would be appropriate to put this in something like OPR, or Office of Professional Regulation, or a technical college or university, because the leading practice, meaning the most successful programs, they're run by peers consistent with peer values. There was another question about the difference between a recovery coach, which we now have recovery coach academies, and the difference between what we're proposing here as a peer support specialist. The difference is one of the scope of practice. I like to think of it as, an orthopedist, a podiatrist, a chiropractor are all eligible to work and qualified to work on someone's ankle, but they all do it in a different way. And it's the same with a peer support specialist. The scope of practice is much broader than a recovery coach, which is primarily, exclusively, and I interviewed the people at the Recovery Coach Academy about this so I would get it right. They're focused on two things: motivational interviewing and finding resources for people to help them curate their own recovery. The scope of practice for peer support specialists is much broader. They can operate as case managers. They can operate as whole health practitioners. They can work in the forensic sphere. They can work in psychosocial education. They can work in what you traditionally know as kind of counseling, but it's not really counseling. It's a mutual peer support. So it's really the scope of practice. And then there was also a question about these entities that would be able to kind of bid to run these programs. Would they have to be based in Vermont? You know, the legislation is silent about whether they would have to be based in Vermont, but I could imagine that it might improve the legislation to put in a requirement that anybody who bids on the running one of these buckets that I described would have to have a Vermont location. You know, what we're after here is providing additional opportunities for people with mental health challenges in the state to get employed, because currently we suffer a lot of employment discrimination. People with mental health challenges have the highest rates of disproportionate unemployment of any population. And it's not because we're not able or we're not willing to work. Surveys have revealed that employers are just not willing to hire us. With 25% saying they would fire us if we hadn't disclosed a mental illness. 70% said they would never hire someone who was currently taking an antipsychotic medication, and half saying they wouldn't hire someone with a mental illness. And then 58% of employees saying they don't want to work with someone with a mental illness. This keeps us underemployed and unemployed. And I have personal experience with this, because despite my experience as an attorney and a businesswoman and a Harvard MBA and being on the faculty at UC Berkeley Law School, as soon as I experienced a psychotic manic episode, I was unemployable. And so this bill creates opportunities beyond just providing peer support. It provided some more entrepreneurial opportunities of starting a business to provide some of these. It creates a career ladder, because once you get this credential, you can stack onto that. You become a specialist. I'm going to specialize in geriatric. I'm going to specialize in people who are criminal justice involved. I'm going to specialize in youth or LGBTQ. I'm going to become a supervisor and get a supervisor credential for peer support. So it creates a peer ladder, a career ladder, and hope for people who are now stuck either underemployed or unemployed. There were fewer questions, I think, on the peer respite portion of the bill. I think I've addressed why not pilot programs. There was a question about why not Addison and Franklin counties, and we say thank you for asking that question. Why not? We didn't include it because we knew it cost money, but hey, yes, why not? All 14 counties.
You picked the wrong county.
You pointed out a blind spot, and we will never make that mistake again, because you're right, Senator Hardy. We do think you can go to Rutland or Chittenden, but no, we want you to have one in Addison. We want people the point is for people to stay in their communities. So thank you for pointing out that blind spot. The other question was about, well, what's happening with the designated agencies and their crisis beds? This is what's happening there. Yes, the designated agencies do have those crisis beds. What we've seen, though, is those crisis beds are not operating. They're not even meeting the departments, or in the past, they haven't met the department's, requirement. They want them to operate at 80%. The most recent data we have is that they're operating more at 70%. And what we think is happening is that people are voting with their feet. They would prefer to be in a peer-run crisis respite. And you're going to hear testimony about a guest at one of those, and you'll learn from her why she prefers that peer-run respite to perhaps something run by the traditional mental health system. So I want to stop there and give other people an opportunity. I hope I've answered your concerns. I'm available for questions. I am gonna dash back over to Senate Judiciary, and I will be right back. But if there's a question before I leave, I would be happy to answer it.
Yeah, you've got one urgent question from Senator Cummings.
Yeah. Does any other state cover peer support with Medicaid?
Yes, 48 states in the District of Columbia have Medicaid, have peer certification programs that meet the requirements of Medicaid, and most of them are billing Medicaid for reimbursement for services.
Okay, so we are outside the norm on that.
Yes, we are with South Dakota on this.
Okay.
Oh,
But
dear.
we also have a waiver, which is unique and has some unique requirements. So
Most states have waivers.
Yeah.
So that's not that unique.
That's
Okay.
yeah, that's a great question, Senator. And we'll, as we go through the bill and ask questions again, we'll rely on Joint Fiscal and DEVA and our Ledge Council to help us. Any other immediate questions? I think this won't be the first time or the last time that you're in committee with us on this bill, Wilda, and I appreciate the time you're taking. So all you have to do is walk around the corner and you're at Judiciary, and then you can run right back.
For me, it's just pushing leave here and join there. So I shall return.
All right, good. Thank you.
Thank you. I appreciate your time.
We'll move on. My question of Commissioner Hawes and Deputy Commissioner Crumph is this, well, I'm looking at Devin Green, who is on a tight schedule. I'm hoping this is going to fit everybody's schedule. Okay, thank you for shaking your head, yes. Devin, thanks for being here, and we'll take your testimony now on 194 and 195.
Thank you. Devin Green, Vermont Association of Hospitals and Health Systems, and I'll keep this fairly brief. I just want to start out by saying we wholeheartedly support both of these initiatives, S194 and S195. As I mentioned before, we have people waiting in our emergency departments. Anywhere from 10 to 30% of the people waiting in our emergency departments are waiting for community options. And don't need inpatient treatment. And so to the extent we can provide more of those community options through the peer operated respite centers, we think that that's a good idea. This will add more resources to the system and provide alternatives to the emergency department. So we wholeheartedly support that initiative. We also appreciate that in the legislation, there is a requirement for those community centers to report individuals likely diverted from emergency departments. We think this is a great metric and should be attached to all of the mental health initiatives, just so we can get a sense of which initiatives are working and which initiatives maybe aren't as effective. So we think it's a great proposal, and we wholly support it. For certification of mental health peer support specialists, again, we also support this. It will provide not only support for those outside emergency departments, but we're hoping to get more peer support inside emergency departments. I think we have had hospitals who have successfully worked with peer support in the past. I think there's a little bit of a cultural block. Our hospitals are rule followers, and if they see an organization that isn't certified or in some sort of framework, they feel a little nervous about working with those folks. So having this in a more formalized framework is much easier, and also so similar to the coaches for substance use disorder. I think that's a lot easier for hospitals to understand. And we've heard that there's been a lot of great back and forth between hospital emergency departments and the current substance use disorder coaches, and a greater understanding between them. And we think it's the peer support for mental health is a great way to create that link in the emergency department to community resources, both for the patient and for the healthcare workers. So wholeheartedly support that initiative as well.
Thank you. Very good. Senator Hardy.
Thanks, Madam Chair. I know you have to run, Devin, but just quickly, I was happy to hear your comment about the hospitals being rule followers and wanting to, I mean, happy they're rule followers, but that you feel like this framework would give them more comfort. And that, do you feel like the certification framework, the way it's laid out in the bill within AHS and then the peer support, that's sufficient to provide the comfort that you're stated?
I do. I think it strikes a good balance between creating some formality to the program and some oversight, but also low barrier to entry. So I think that's what we're looking at right now. We want to get people involved as fast as possible and in a way that is aligned with the values of peer support. So I think this strikes a good balance.
Great. Thank you.
Good question. Thank you. Okay. Anything else, committee, for Devin? All right. As we go through the bill and we make changes or look for clarification, we'll have you back, or if you need to review the language with us, that would be helpful. Okay.
Thank you.
Thank you. All right. I think we can move. I'm looking at the commissioner and the deputy commissioner and asking for your testimony now, or would you prefer to wait until after others have testified?
I think our plan was really to just open with that we support these initiatives. This is something that the Department of Mental Health has integrated into some of our plans. But when I look at the folks who are here to testify today, I think that it makes a lot of sense to hear from the rest of the group. I'm happy to stay on and offer any DMH supports or answer any questions post that opportunity for folks. But I think we all have the same end in common, and that is that folks are getting the right kinds of services when they need them and where they need them. And I think this is a valuable tool to that. And so I'm excited and honored to be a part of testimony and to hear from the rest of the group.
All right. Thank you, Commissioner. So and thank you for that support of the bills. We'll move on then to Stephanie Winters of the Vermont Medical Society. And we'll just go in the order that people are listed on the agenda.
Great. Thank you for having me back. So Stephanie Winters, I'm speaking on S194 and 195, and I'm wearing my Vermont Psychiatric Association hat. And I want to speak in support of both of these bills. We see both of these pieces of legislation as steps in continuing to build the mental health infrastructure while putting standards in place and creating a certification for peer workers in order to ensure qualified staff. So very supportive. And I just wanted to include a couple of quotes from members. You still can't hear me? That's so weird.
It's echoing. It's just difficult. That's all. It's
okay.
Yeah.
I'll speak really loudly. Is that better?
Sure.
Okay. So just a couple of quotes from my members. They've had dozens of patients who've used Alyssum or Sorteria successfully when experiencing significant levels of distress. The peer-run programs are careful about who they accept, and in their experience, the vast majority of clients are highly satisfied with the services they receive. The opinion is that the more hospital diversion options that we have and that patients have, the better. And we're in favor of having as many non-medical options as possible for those who prefer that route. And one psychiatrist said, in all honesty, if I was in significant distress and had a choice between a psychiatric hospital or a peer-run program, I would choose the latter. Another member goes on to say, many of the patients I've seen in the inpatient setting and in the emergency room would benefit from having respite facilities like these to go to. Most need a few days away from their stressors before they're ready to get back to it. And many don't need or even want to be in the hospital, but they have no other choice. This would free up some of the inpatient beds to those who would benefit from hospitalization and more economically alleviate congestion. The beds could be used as hospital diversion, ED discharge, or step down from the hospital. So those are just a couple of examples, but again, my testimony is really short. We support both of these as tools in the toolbox to help support our system.
Thank you. Can you get us a short paragraph or two on your written testimony?
Yeah, it was actually included as page 3 in my
It is on
testimony.
page 3.
Yeah,
That's right.
sorry, I combined the two.
I remember. It's just not in front of me right now. Thank you. Okay, questions? Terrific. We'll move on to Hillary Melton, who is here from Pathways Vermont. I think also called Solteria. Is that accurate?
It's one of our programs, Soteria
Yes.
House.
Oh, yeah. Okay. Hillary, thanks for being here.
Yes, thank you all. For the record, my name is Hillary Melton, and I'm the founding executive director of Pathways Vermont. Our mission is to end homelessness and provide innovative mental health alternatives. Today, I'm here to testify in support of S194 and S195, acts related to peer-operated respite centers and certification of mental health peer support specialists. I'm in Winooski, and there's a plane thing that goes on here. Can you hear that? Sorry.
So I'm glad it's over Winooski today, because usually it's over me. Williston.
It's the Winooski pause, I've heard.
Yeah, it is.
And since Pathways Vermont began providing services 12 years ago, can you hear me when they go by?
Yes,
You can
you're
still
fine.
hear me. Okay. It was clear that Vermont's system of care was lacking in alternatives to hospitalization for people experiencing mental health challenges. Time and time again, people who are struggling, people who are in need of support, and people who simply do not feel safe alone turn to the emergency room for relief. One bright spot in Vermont is Vermont's only peer respite, Alyssum in Rochester, Vermont. However, the problem with Alyssum is that it is always full and there is always a waiting list. We have a model that has a 10-year track record of success. With S194, we simply want to invest in what is working so Vermonters have access to peer respites and don't unnecessarily go to the hospital. S195 is a tandem bill to the peer respite bill. Currently, mental health peer support is offered in Vermont without any standards of experience and training, no competency standards, and no ethical standards. If it becomes law, S195 would validate the discipline of peer support as a distinct practice, define the scope of practice, standardize qualifications and competencies, and allow services to be billed to Medicaid, which would reduce the state's costs. These last few months, as I have been meeting with legislators in the community about S194 and S195, a question invariably comes up that I would like to preemptively answer today. The question is this: do Vermont's peer organizations have the capacity or the knowledge to be able to get 7 peer respites and peer certification programs up and running? The answer is a resounding yes. We are a strong, capable group of organizations. I want to share with you a little bit about my organization, Pathways Vermont, as an example. Pathways Vermont provides services in every county in Vermont. With a $9 million+ budget, our funding partners include the Substance Abuse and Mental Health Service Administration, the United States Department of Housing and Urban Development, the Vermont Department of Mental Health, the Vermont Department of Corrections, the Vermont Department of Aging and Independent Living, the University of Vermont, and various local United Way chapters, local towns, cities, among others. Pathways is a specialized service agency for the Department of Mental Health, and we bill Medicaid for Housing First services, an evidence-based model that we introduced to Vermont in 2009. We have been writing service plans, documenting service delivery, and billing Medicaid for over 8 years. Just last quarter, our Housing First program logged approximately 4,000 hours of service delivered in person and in the community. Pathways currently has 128 employees, and 80% of us, including myself, have a variety of lived experiences of mental health challenges, substance use, homelessness, incarceration, and/or trauma. We practice a relationship model of support informed by intentional peer support, a curriculum developed by Sherry Mead. In addition to our work ending homelessness, we also operate several innovative mental health programs, including the Pathways Vermont Community Center in Chittenden County, the Pathways Vermont Support Line, which is a statewide service, and our Soteria House that Senator Lyons mentioned, a 5-bed licensed residential program available to anyone in Vermont. For the past 2 years, we have spearheaded the Department of Mental Health Peer Workforce Development Initiative, whose purpose is to improve consistency, infrastructure, communication, and resource sharing among the peer workforce community. I am here today to assure you that we are ready, willing, and more than able. Thank you for your time and consideration.
Thank you, Hillary. Do you have that in writing? Is it possible to get that?
Yes.
That would be great. Good.
Sure.
It's extremely informative, and just remembering the time when Pathways first came to the state, it's really matured as an organization. Thank you. Morning Fox is here. So, Morning, are you there? I should have asked any other questions. I didn't see any hands up. Okay. Morning. Thank you for being here again.
I sure am here, and thank you for having me. Again, for the record, Morning Fox, Director of Mental Health Programs for the Department of Public Safety. I will keep my comments brief. S194 and S195, complete and utter support from both myself as an individual, as well as the Department of Public Safety. This is something that I have been in support of for many years. I think Gloria has even heard me talk about Alyssum as a model for all crisis beds throughout the state in the past, and that's has been my position and continues to be my position, even though I'm not with the Department of Mental Health anymore. That was my position then, and it continues to be to this day. The other piece in particular is that this does have a direct impact on the work that I'm doing in public safety as well. As I mentioned in some of the work I'm doing in looking at developing an alternative response model for our state, I want to include in our response model people with lived experience as part of that response model. Most of the response models, not all, but most of the response models that have been developed across the country include either licensed social workers or other mental health quote unquote professionals, along with maybe an EMT or specially trained officers or something of that sort. There are a few that are starting to include peers in that type of response. And from what I've been able to gather in my own research, they've been extremely successful as well. And everything from the Bureau of Justice to SAMHSA to other federal agencies also support the use of peer support workers, not only as we've been discussing in the testimony today, but also in kind of the crisis response as what I'm looking at. So again, I'd be in full support, and the Department of Public Safety is in full support of both S194 and S195.
Thank you. Terrific question. Senator Hardy.
Thank you, Madam Chair. This is a question probably for both Mr. Fox and perhaps Ms. Melton. And I'm wondering if either of you have experienced any community pushback for the location of peer respite centers, and whether, Mr. Fox, if you work with law enforcement to ease any concerns about the placement, and then Ms. Melton, how you have dealt with those concerns. I'm just thinking if we're creating a several new ones, how do we as communities, get over this hurdle, which I imagine probably exists. Maybe I'm wrong, but just wondered if I could hear your thoughts on that from both of you.
Hillary, would you like to go first?
Sure. We opened our Soteria house, I don't know, 7-8 years ago, and there was surprisingly no resistance. And that's on Manhattan Drive in, in Burlington. But we did do what we would do. We did do community outreach. We went door to door. We knocked on people's doors and had conversations. We met with the local police. We went to community meetings. So there was definitely footwork that we did ahead of time to discuss what the programming was about and be open to questions, as we do with everything. I think the way to diffuse those stories is to open up a conversation ahead of time and use it as an opportunity for learning for everybody.
I would add to that my experience, and I'll speak to my broad experience, over the years. I have not experienced community pushback or concerns of like a peer-run respite facility any different than there has been the NIMBY kind of pushback to a crisis bed in general because of the clientele, not because of the staffing and such. And so I think that's been an issue in the past. And I can also speak just positively about, from Department of Public Safety perspective, when we've had conversations about this, and that our sense is that the addition of peer respite centers throughout the state are only an added benefit to all the work that we're doing, and that the work I'm trying to focus on is how do we have an alternate response to people so that we can help avoid individuals unnecessarily going to the emergency room, unnecessarily becoming involved in the criminal justice system, things of that sort. And having added resources of peer respites and crisis beds that could be an alternative to an individual's an alternative to providing supports for an individual's needs is only a benefit. And so Department of Public Safety is in extreme support of both these concepts.
Well, that's great to hear from both of you, because I imagine just creating new facilities in communities. I want one in Addison County. I've been clear about that, making sure that there's support for those new to work with local law enforcement, because I have heard pushback about various programs, not specific to peer respite, but just wanting to, if Ms. Melton has a formula that she's used that's worked and there hasn't been pushback, that's great. Let's replicate it. So thank you both.
Senator Hooker.
Thank you. This is a logistical question. I know, Ms. Melton, that you said your staff is ready, willing, and able. What about citing the centers? Do you feel, and I know you work a lot with homelessness and putting people into secure home-like situations, do you see a problem with finding enough space for new centers with the lack of housing that we have throughout the state?
There's a lack of housing, but I don't know. There's always opportunity. When we seem to continually find new landlords who are willing to work with us. There's people that want to help and support a system of care. Most people have family members, if not themselves, friends who would benefit from these kinds of services. So it's opening up conversations with people and appealing to their needs as well. We have been fortunate, and we have great staff. Speaking for Pathways, we have great staff on the ground that have a lot of landlord connections. And in each individual community, I think we would, Ken, who's here, Ken Russell from Senator Cummings, your town in Montpelier, another way. I think we'd all work together to find the appropriate spot and make it work together.
Okay. Thank you. So I think we'll move along. Gloria Vandenberg is here, Executive Director. So will you introduce yourself, please?
Yes, thank you, Jenny. I'm Gloria Vandenberg. I'm the founding Executive Director of Alyssum. I am now in my 11th year. And I'm going to address three things today that came up in some of your past questions. The first one is startup. And the second one is who are our guests, where they come from. And the third one is accountability. And I will pause after each one and answer any questions that you may have. Startup, is Alyssum set to be startup? We just talked about startup. I will say that both on our website and in some of our written stuff, we have gotten letters and videos of our neighbors and townspeople thanking us for having Alyssum in their community. I have people that come up to me on the street and say, we're so happy you're here. People use it that are local, people who are local who have family members who are suffering from mental health issues are appreciative that we have something that different in town. So we did have pushback at startup. We did have to talk with the town. We had many meetings. They required us to do an additional screening process to start up, which has been helpful in the long run for us. So as far as zoning and location, we are looking to set up 2-bed crisis respites, which will not need licensure. Alyssum doesn't need licensure. We may have zoning variances that will apply. We had to get a zoning variance for Alyssum, although it was on Route 100. We had to get a multi-use zoning variance to have that there because it's more than a domestic residence. We carry insurance. We carry all kinds of insurances. So our connections for insurance are all set to go. Our program, it's built. We've been piloting this for 10 years. We have all the documents. We have all the pieces of paper. We know how to do this. We've done this before. We know we have to set it up to be handicapped accessible. We have to be able to make whatever adjustments and changes to that. We also know that a program like this, even though we are so rural, Alyssum is 1,200 people in the middle of a valley between two mountains, and people come from almost all over the state. And we have a long pending list. So we know that people can get there. We know that we have some flexibility about where if we say we want to build a place in Barry, we know we have some flexibility around where exactly it needs to be. It doesn't need to be right next to the hospital. It could be out of town a little bit, or it could be in town. So I think that we are all set to go to build something. We've done all the groundwork. Hillary's done the groundwork with Soteria. We know we know how to do this. We know how to start something. Do you have any questions about that? So our guests currently are being recorded as mostly self-referrals. That is because our guests come from all over the state. They're being recorded as self-referrals. Now it's kind of a gray area because many of our guests come from designated agencies. Now you've got to bear in mind, these designated agencies also have their own crisis beds, but they're choosing to come to Alyssum. So when somebody who's been there before calls us from a designated agency and asks to be put on the pending list and does their intake with us, we log it as a self-referral, even though they do have a case manager and they do have a psychiatrist and they do have other services and they are getting a ride through their designated agency to our program. We still log it in as a self-referral. But we do a lot of work with hospital staff. We do outreach presentations to hospital staff and other group homes and programs. We have relationships with all of the designated agencies. We have relationships with Washington County emergency services teams who are our fallback should we have to make an emergency call, which we make very little of. We have a very strict and clear screening process that is dedicated to keeping our other guests safe and keeping our staff safe. We don't take in just anybody. And we need to talk to the person individually before they come in. We don't just take a referral from a case manager who says they have somebody who's a good fit and take them in. We have to talk to the person. We have very low incident to no incident. It doesn't mean that we're not taking people who aren't acute. It's the screening process and the interview process and the conversation that we have before somebody comes in is what protects the program and keeps everybody safe. We have a very well-trained staff body who knows what they're doing. So that's our guesting. We have more women than men, which is normal. We have transgender or non-binary people that come. We have non-binary staff members. We have male and female staff members. Do you have any questions about who is our guest? Yes.
Senator Cummings, and then I'll ask my question, and then Senator Hardy, sorry.
Okay, I understand crisis beds, okay? But you've got a 6-month waiting list. A crisis doesn't wait 6 months. So what are you doing?
Well, we have on average 5 to 9 people on our pending list. If it goes over that, we are telling people you should be trying to find something somewhere else. People fall off of it. People don't make it in. People either wind up going to the hospital or feeling better. When our pending list is that long, the people on it are eligible to make warm line calls to the staff, so that our warm line calls are like around 250 calls a month. So yeah, no, but we have to have a list. So it is difficult. You know, we get all these people who want to come into the program. The thing that this program does, okay, that's different from other crisis beds, is this program works one-on-one with people. It does, like, I want to call it therapy, but it's not therapy. It's a mutual meeting of the minds. It's a sharing of ideas. It's giving skills to people, so that when they leave, they're leaving with more skills and more ideas and more ways to take care of themselves than when they came. And that's different than going into a crisis bed, taking your medication for 3 days, stabilizing, and going home. So it's really a very interactive program. So, and I think that's why people try to wait, and they try to hold on, and they try to wait.
Thank you.
Senator Hardy, go ahead, and then I'll ask mine afterwards.
Thank you. Ms. Vandenberg, how long is the average stay for somebody once they get in? So what's the sort of turnover rate?
5 days.
5 days.
5 days.
So within 5 days, people feel well enough and stable enough to be able to move on back to their lives.
So this is that's an average. So let's say we take somebody who's a step down from the hospital, all right? They've been through 3 months of hospitalization. They've had major medication adjustments. Their home is blown up. They don't have a home anymore. They're having to go to a motel next. That person might be with us for 2 to 3 weeks. Then let's say we have somebody who calls us who's been to the program before. Their cat just got run over on the road, and they're having a crisis about their cat that got killed. It was their favorite cat, you know, and they're just really fragile. They know all the staff. They can come in for 2 days. We bump them in before the step down gets there. They come for 2 days. It just helps reset them. They stay in touch by phone, and they can go home. So when we start averaging out the days, we got down to 5 days.
Got it. That's great. Thank you.
I have a question about the person who has a depression and may have thought about suicide, and that do those people self-refer, or do you see families bringing folks in when they're sort of in a crisis?
We have families call us, and say, my son needs to come in or whatever, but we really need to talk to the person themselves. They have to want to come to us, and they have to understand what we have to offer. So we would count it as a self-referral once that person wants to wants to come. But say it was something like you're describing, somebody who's extremely depressed, the town asked us to do this screening process, right? So let's say in your case, what the screening process that the town put us on is that we would call somebody who knew that person well, who was in the medical profession, that could tell us about this person, because they didn't trust us as peers to be able to do that for ourselves. So we took that on, and within 2 years, the town said, never mind about all that. You guys are doing a great job. We're not worried about you. You don't have to do any of that stuff. But we kept it because it was really helpful. So that somebody who's really depressed, like in your example, somebody who's really depressed and they called us, we would want to talk to their psychiatrist, their case manager, their somebody other than their family. We would want to know that they don't need medication, or that they're stable enough with, that they're not going to go, that they haven't just taken all their medication away and are going to go into a deep dive while they're with us, because we don't provide medication. We don't have nursing staff. We do take people who are suicidal. We take them all the time, but we're very careful that we can provide them with the services we need. And we do that through having the conversations that we need to have with them.
And this, as a follow-up question, or it's actually separate, are you seeing people from all socioeconomic levels, or is it?
Yes.
Okay, thank you. That's helpful.
We see medical professionals,
Yeah.
people who are case managers and psychiatrists.
Okay, you had one other bucket.
Okay, the last one was accountability. I think Wilda White gave you several pages of our grant to put into testimony. But I wanted to assure you that we are very accountable for what we do. We report monthly to the Department of Mental Health, and we report quarterly. Our quarterly report is much more lengthy. Our monthly report is basically covers about 40 items. The Department of Mental Health, according to our grant, requires us to report census at 80% or more, admission, 75 people annually or more, goal satisfaction, 85% or more, program satisfaction, 85% or more, departure satisfaction, 75% or more for being better off, and staff turnover. Our census occupancy this year to date is 86%, and that includes the fact that we were closed for 10 days because staff came down with COVID. Our admission this year is probably going to be around 88 or 92 people, and they're only requiring 75. Our goals, satisfaction with goals, 85. DMH requires 85%. Right now they're at 93%. Overall program satisfaction is always between 98% and 100%. Staff turnover is either less or at 10%. Our acute service reduction, it's a survey we do. DMH requires our acute service reduction. That's people reporting that they're having used Alyssum and continuing to use Alyssum is reducing their need for emergency medical services. DMH requires it to be at 75%. Our records right now are at 97%. 100% of the people who come to us would recommend the program to another person.
That is a pretty good record.
And it's been consistent over the last 10, 11 years.
I have one question, and then probably we should move on, but so the bill that we have before us is looking for expansion. Will the organizations that we put in place be able to have a similar report? So we'll be able to have a 86 to 90%.
Well, we certainly hope so. The program is based on its executive director, and I am directly involved with all of us who are trying to make this happen. This is happening because we built a good staff team. I mean, we have long-term staff. They've been there for a long time. I think our average staff length of employment is 7 years. I mean, the only way you get to be a staff at Alyssum is if you get in on a per diem basis and you manage to, you wait till somebody else quits. So that can be quite a long time. So I think if we have the good training in the state, we hire people with good core competency. We have the recipe. You know, the recipe is here. We know what kind of training people need. We know what our intake is. We have all our paperwork. We know how to do these things. Pathways has a lot of experience doing these things. So I think that between the lot of us, hopefully we could come up with more programs that would be like this. I think that people with lived experience really enjoy being with other people with lived experience and feeling better, learning things, coming home feeling like they've gained something rather than just been medicated better.
Okay. I guess an overall question that I would ask for all of you, and you don't need to respond right now, but as we're thinking about expansion to every single county, then will the beds be full? And obviously today we say absolutely, and then it would, what would be neat is if over time we had less and less of a requirement, but we don't see that right now. We probably don't see it in the near future at all. We probably should move on. And Linda Lamoge is here. Thank you for being patient, and you are here. Go ahead and introduce yourself.
First of all, I'm so appreciative to be here and listen to the input of all the previous speakers. I also share many of the concerns for the issues previously discussed this morning, and there are often obstacles, but I am so grateful to have these discussions to help remove those obstacles. My name is Linda Lamoge, and I currently reside in Bennington County, Vermont. I want to express my gratitude for this opportunity to offer support for this truly invaluable program. I'm both honored and intimidated to be a recipient of services. I have been using the services at Alyssum for nearly 10 years now. This may be considered my story. However, our personal stories all share common threads that are woven together by our existence within humanity. Trauma may occur at any time in one's life, and PTSD can affect people in all walks of life, regardless of education, socioeconomic status, or age. This is my truth. My formative years were challenged by a considerable amount of adverse experiences, which in turn resulted in PTSD, chronic pain, and a number of other various labels which hindered my path like having untied shoelaces, until I started going to Alyssum. I spent much of my life trying to disengage to avoid uncertain situations. Working together with a caring, non-judgmental team at Alyssum and engaging in peer support has taught me to disengage from unpredictable triggers when they present themselves. Then a few years ago, a very sudden and unimaginable trauma occurred, which totally shattered the lives of those involved as well as my own. My sense of self was greatly fractured, but my sense of hope was restored by the constant support of those at Alyssum. I regained my will to live, and I found my way through my grief with meaning and purpose. The reason which peer support worked so well for me was that I knew that each person who was working with me truly understood my circumstances through common experiences. I was not there to receive a label or be inundated with sedating medications. I was there learning basic self-care skills, which greatly improved the quality of my life and still provides me today with the tools for coping with additional stressors. The environment is nurturing and home-like, with opportunities and spaces for cooking healthy meals, writing, art, music, meditation, yoga, dancing, gardening, engaging with nature, and playing with their dog Prince. All conducive to self-reflection and personal growth. Contact with Alyssum has also helped keep me sober, has improved my interpersonal relationship skills, and reminded me to relax as well as play. However basic all these may seem, these activities, which are so essential to the very nature of our personal well-being, have enhanced my quality of life through self-care. I have shifted from having dissociative behaviors to becoming more grounded. I am no longer hidden beneath my shield of shame, which prevented me from moving forwards. Today, I thrive. We not only need Alyssum to continue, but it would be advantageous to emulate this program in order to benefit the growing needs of others. My wish now is that the lives of other Vermonters may be enhanced as well through implementing additional programs. After listening this morning, I added that aside from the needs for funding and my lack of understanding of the logistics, I am surprised to hear that turning towards the Medicaid model is expected to improve the services. I have never had an issue of competency or ethical standards with any of the staff on the Alyssum team. While the traumas of the past still remain in the outskirts of my mind like shadows, I now have the ability to remember that the sun is always there, even on the cloudiest of days. And thank you for listening.
Thank you for sharing. That is very powerful and greatly appreciated.
I have grown so much in the past 9+ years through my relationships with all of the people at Alyssum, using both the services of going there and spending time, sometimes a short stay, like 2 to 3 days, and others longer, but also being able to use the telephone and having it be consistent with people that I recognize, and they know me and they've known me over the years. And it's been very helpful. And I wished for so many years that Alyssum would be available to more people. So I would encourage that.
Well, we'll see what we can do. It's just, this has been a very powerful day in terms of testimony. So we're moving in the right direction to respond to your request.
I appreciate that. And if there's any way that I can be of assistance, I'm sure people know how to get a hold of me.
Terrific. Thank you. Thank you very much, Linda.
Thank you.
So we're going to move along, and we have Sarah here. That's correct? SERA. It's an unusual spelling, but
it is. And I was going to be. I was supposed to be sharing slides, but it seems like that's disabled. I don't know if that's.
You can share slides.
Oh, it's allowing me now. Something must have changed.
Yeah,
okay.
yeah. No, you just have to ask, and we can have you put your slides up.
Great.
And so please go ahead and introduce yourself for the record, and we look forward to your testimony.
Sure. So thank you for having me here. I think I might be the only person who is testifying who is not in Vermont. And so I just want to say briefly why I was asked to be here today. So as you said already, my name is Sarah Davidow. I'm here today because of my work based in Massachusetts and on the national and international peer respite fronts. In 2006, I actually wrote a grant for what is now known as the Wildflower Alliance, which formerly was the Western Mass Recovery Learning Committee, and I became a part of their leadership team when it was first funded in 2007. And the Wildflower Alliance has many parts, including community centers, support groups, and a training and consultation division, and we are entirely peer-to-peer. In 2011, I wrote a grant for AFIA Peer Respite. You'll see some information about AFIA on the screen here. I also wrote a second grant to retain the contract in 2017 when it went out for automatic rebid, which is just a part of the Massachusetts regulations requiring rebidding every so often. And that same year, the Wildflower Alliance published the Peer Respite Handbook in collaboration with Intentional Peer Support Central, which is based with you all in Vermont. And I served as the primary author, and it remains the only comprehensive peer respite handbook currently available. And then in 2020, I and my coworkers offered several presentations for and consultation to a national peer respite and Soteria House summit. And AFIA was also recognized by the World Health Organization as one of about 24 exemplary rights-based programs in the world. Over the course of these years, I've also had opportunity to visit several other peer respites, including California, New Hampshire, New York, and Maine, as well as similar types of programs in other countries, including Denmark and Germany. And although I'm mostly going to be focused here on S194, I do want to add that I was a trainer for about a decade for the Massachusetts Certified Peer Specialist Training Program, as well as a curriculum developer for them. And I continue now as a offering continuing education for certified peer specialist people in Maine. So it is with that experience in mind that I'm testifying before you today. And as you may or may not know, peer respites vary in many regards, but those that are following a true vision of what peer respite was meant to do, they share several things in common, and those include being voluntary in nature, being building a team of supporters who all have some firsthand experience with life-interrupting emotional distress, psychiatric histories, trauma, and similar. And they all have a mission that is geared towards turning what so often gets called crisis into a learning and growth opportunity. And so I just want to talk quickly about what you'll find if you were to look, and I did include links if you do want to look directly at some of the guidance that I've mentioned. So in the Peer Respite Handbook, there is a lot of information that touches on what y'all are talking about today, but particularly I want to focus on the idea of peer respites as connected to community centers, because there is something really important. I think peer respites, obviously, Alyssum has had tremendous success, even though they operate pretty independently. But there's something I think really important about the idea of peer respites connected to community centers. And you'll see in the handbook, I just pulled out an excerpt, that there's a couple of just things mentioned there, including that it can pave the way to a continuing relationship with the organization even after leaving the respite. So I know that Alyssum and others have accomplished some of that with phones, but having a community center that people can be connected to after they've been in respite or before as a way of learning about the respite can be really powerful, and also creates an automatic partnership and extra support for the respite team. When things are difficult there, extra support is needed, people are out unexpectedly. You'll also find in the World Health Organization guidance documents that the section that is about AFIA specifically, there's one piece highlighted there that I really want to emphasize, which is that individuals don't need to be in crisis to access support if there's a community center available and other supports available in addition to the peer respite. I think that's so important, because I think that we can really get into this place of kind of training people almost to be in crisis in order to get support when there's not enough of a network available. This is a slide that I often use in trainings on suicide. We do a lot of trainings on something called alternatives to suicide. And I've added an arrow here, this black arrow over on the left, which says, one of the reasons people say they're suicidal is because the system trained them to say that in order to get services. And there's actually a number of things like, a lack of housing, and no one listens to people if they don't say something sort of more extreme sounding, that are highlighted on this chart as well as reasons why people say they're suicidal. And the ability to form a broader network of not only the peer respites, but also of the supports that surround them, like community centers, which I know is one of the focuses of S194. It's just so important to breaking that cycle. And when that when there isn't a broader community that they're a part of, the risk increases that the respite becomes this life raft rather than a bridge to a full and meaningful life. And it also increases the risk of replicating what I was just talking about, the must be in crisis to access support mindset, which, if you've done any work in the mental health field, it's just such a pervasive issue that people learn how to meet their needs in ways that are not actually always so helpful to their lives. And it also risks relatedly, increases the risk that people will get into the cycle of being in and out of services rather than kind of getting to a point where they have the supports they need and going on with their lives. So I really can't emphasize enough how important it is that there be those broader supports connected. And when I say those broader supports, I really am talking about peer-to-peer supports. I think there's so many clinical supports that people find value in, and when they're coming from different philosophies, can be a lot that gets lost there. So a peer respite that is surrounded by lots of clinical supports can still have great value, but when someone leaves the peer respite and they go back to the clinical supports, the approach often changes dramatically, and it can undo some of the progress for some people that they were able to make. It's just not quite the same. And there's lots of people who are just avoiding clinical supports based on past experiences, and particularly experiences that have led to loss of liberty by forced hospitalization or similar. And I think the peer respites really are able to maintain a connection, as well as the peer-to-peer centers, that sometimes the clinical system, even if it's offering really useful things, isn't able to. But I also wanted to emphasize the importance of having enough respites. I know the point here, and it sounds like there's a tremendous amount of support in the state for that. The point of peer respite is, there's many, obviously, points, but one of them is to try and support people to not have their lives be massively disrupted by things like being inpatient in a psychiatric facility, and again, catching people who might otherwise be avoidant of supports until they are really at the worst point possible and no longer have the option to avoid. And one of the things we struggle with in Massachusetts is that for most of the time we've been around, we've been the only peer respite in Massachusetts, and we have 3 bedrooms in one house in an area that has 8 psychiatric units with I don't even know how many beds. And so the thing I have on the screen is from 2017, one of our annual reports. We certainly have more recent statistics, but not as neatly put together in an annual report. So I pulled this. And what you'll see here is that of the contacts that we received in 2017 that did not lead to someone staying at the peer respite, 990 of them were due to we had no space. And if you go back, I put also there 2016 and 2015, you'll see 899 and 724 contacts did not lead to a stay at peer respite because we had no space. And when we talk about peer respite as having a fundamental purpose of hospital diversion, I don't think staying out of the hospital has to be the #1 top listed thing for anyone ever, but it's really important to a lot of us. And when I see this, what I really want to emphasize here is it's impossible to have peer respite fully realize its potential, or any alternative fully realize its potential, if it doesn't have enough access, and if the clinical supports remain the ones that are actually most available by choice or by force. And so I really appreciate that Vermont is doing something that Massachusetts has not yet done, which is to really push for there to actually be access and actual opportunity to see the true impact that this can have. So as I think you've already heard from others, there's a growing body of research out there that tells us that peer respite and peer support in general is effective. I often cite the research specifically from Human Services Research International on second story peer respite in California that shows marked decline in use of inpatient psychiatric facilities for people who engage with peer respite. And someone asked earlier, I forget who it was, about whether or not 5 days is enough. That respite would suggest that 5 days is enough to really impact that for a lot of people. And that actually those returns start diminishing after you go over the 2-week mark. So there's a window in which it becomes really impactful. And then after, longer stays, it starts to diminish the actual impact. So yeah, I'm not going to tell you that peer respite is absolutely essential for everyone, but it has a really big impact for a lot of people, even though it sounds quite short. And this does mean that there's significant cost savings for the community, and that's great because peer respite is absolutely less expensive than psychiatric facilities or clinical crisis stabilization units as well in most instances. But I guess one of the last things I just want to offer you is that we get caught up in cost reduction far too often. It is important, but even if the costs were equal, it's so much more humane. It's so much less traumatizing. It's so much less disruptive to people's lives. They're able to go get jobs, and that's a different sort of loss and gain for community because they're not being pulled out by going to a psychiatric facility. There's so many other things they're able to realize in their own lives and their own dreams. And again, we're catching people who need support, but are afraid to get it from the clinical system based on past experiences or the way that things get approached. Peer respite is also really a harm reduction approach. And I know you're probably most used to hearing that with drugs, but I would say with suicide, with hearing voices, with all the things that peer respites address, there's a harm reduction approach there that doesn't say, we must get rid of this in order for you to go on and have a full life. In fact, what we focus on more is changing, supporting people to change their relationships with suicidal thoughts or hearing voices or things that might be distressing them so that they can have a sense of power over them and see them as signs or messages that maybe something in their life isn't working or what have you so often. And for so many people, they're just not getting that in the clinical system. So there's so much that is so important in how we approach things differently. And ultimately, this does require funding, as you all know. That's why we're here today, and enough access so that the peer respites themselves, as well as the networks of support around them, can be built and really the impact can be fully realized. And so I think with that, I'm just gonna say, I ask that you support S194 in its entirety. And I so appreciate that I'm already hearing that people are really speaking in that direction. So thank you.
Oh, thank you, Sarah. And why don't we take your slides down? Good. Thank you very much. That was very comprehensive and informative. So, and I'm thinking that your work is informing the work that is going on in Vermont or potentially will go on in Vermont. So, and I'm looking at everybody who has testified for your shaking your head. Yes. Yeah, that's great. So I also will ask if there are any questions of Sarah at this point. It's good. And we have your slides. And your annual reports have a lot of data in them. So we may want to dive into those at some point, but I think the information that Wilda and others have provided will be very useful. Senator Hardy.
Thank you. I don't know if you'll be able to answer this, Sarah, but you're located in Western Massachusetts, or your program is Western Mass. And we heard from a witness. Thank you, Linda, for your powerful story from Bennington. And if we, Vermont, were to create more of a network of peer respite centers, is there ability for patients to go across state lines to access these services? Can Vermonters go to your program and Massachusetts and whatever come to Vermont programs? Or is that not feasible?
It really depends on how the contracts are written. I will be honest with you that technically we're supposed to primarily serve Western Mass, but some people, say in Brattleboro, are actually closer to our peer respite than people really in the far reaches of the Berkshires. So we do make exceptions. I think that it can be challenging to support someone to get rerouted in their community after leaving the further away that they are. And so it's not ideal, but in the absence of supports, I think I would love to see us go in the direction where we're not so obsessed with, exactly where the lines are, and we're more focused on how do we support our communities, how do we support our people. So I think we would be certainly interested in and open to that conversation about how to support each other and each other's communities in that way.
Thanks.
And of course, payment programs would have something to say at some point, whether Medicaid crosses borders or not. That's always an interesting conversation. But having an open system would make sense. I see that Ken Russell is here. Ken, were you here did you want to make a comment, a quick comment, or?
Sure, and I was invited by Aaron. I'm glad to be here. It's a really fantastic conversation. I'm the executive director.
Okay, go ahead. Yes, thank you.
I am the executive director of Another Way in Montpelier. I grew up in Brandon, so right between Senators Hooker and Senator Hardy's districts. And we've had a community center at Another Way for 40 years. And all the sort of person-centered, community-centered values that we're hearing here have been evident there. The the bringing together. I mean, we deal with law enforcement, we deal with hospitals, we deal with all sorts of service agencies. And we see, I mean, we have a holistic approach. We have a fantastic community center with great amenities. We have a well-regarded wood shop and a wellness center, greenhouse. I'm honored to be there. And it would be fantastic to be able to extend our reach and connectivity with folks who could actually, you know, stay in the oasis a little bit longer, and in a non-medical setting. And we have people flowing right in off the street. And we really do provide a respite from 9 to 5. It's heart-wrenching when we have to close the doors and somebody has to leave, and they have no place to go. And we've had folks in various states of extreme mental distress leaving at that time. We do work with you know, peer outreach workers, street outreach workers, a whole network of care that is tightening and getting stronger all the time. But there are real gaps. We are told by the police that, you know, they'll bring people they don't know what to do with to us, or the hospitals will send folks to us. And we are adept at filling in the gaps. And you know, partly because we're, you know, the rule follower thing was interesting. I mean, we are largely unconstrained in how we respond. And we're able to, you know, follow human to human. What are the human needs here? How do we meet each other? How do we support each other? It's a fantastic place to work. And I'm learning a lot in this conversation. The collective learning we're all doing and building a stronger fabric of mutual care is fantastic. And from, you know, from at every level. We have a great supportive employment program. I mean, and I said, we have folks who are peers who come out of Ivy League colleges. We have some who are just barely scraping by in destitution. And yet we're an integrated community of mutual care. So I'm glad to be here.
Well, thank you for joining us. And I'm pleased that you were able to make comments. Your program is 9 to 5, which is different from what we've been hearing about with the others. And I guess going forward, it would be interesting to know a couple of questions I have. One, do you work closely with Washington County Mental Health for folks who might need a place overnight? That's one.
Yeah, we certainly work with Washington County. We have good relationships with different folks there. And yeah, and you know, but finding the overnight space is often dicey.
Yeah.
And
you consider expansion into something more like an Alyssum or other pathways? Okay.
Yeah, absolutely.
Yeah, thank you. All right. We're getting close on our time, but I do have two very general questions for both the committee and for those of you who are on the in the meeting. And one is that what I understand is that the peer support programs that we're talking about are really designed for adults. So am I right in that? Is it 21 and older? No, 18 and older. Wilda, do you mind?
Actually, I think some of the grants would restrict the age. And so like for Alyssa, you know, we get money from the adult mental health care system. And so adult, I guess, is 18. But, you know, there's flexibility in designing some programs around, you know, younger ages, maybe not, you know, not 10.
Yeah.
But maybe 17.
But there's a potential then, and Commissioner, why don't you weigh in on this?
Well, I had raised my hand just to make sure I'd had an opportunity to get a couple of comments in.
Oh, you were going to get more than a couple.
So, but I had, conversations with Wilda about, what specific around the age groups and what the flexibilities could be to explore. So I don't have anything further to add for that, just a couple of other comments on behalf of the department. When you're ready.
Go ahead.
Okay. So first, I just wanted to say thank you to those who testified today and allowing me to be a part of that. A couple of items I just wanted to highlight is that DMH, as a part of our BAA, has funding proposed to explore the peer certification process with stakeholders. So just wanted to make sure that that got highlighted, that is something that we have as a part of our BAA. And then once we get into, further bill review for this, the department can help provide detailed review around feasibility and implementation. So I know that's coming further down the road, but just wanted to make sure we had an opportunity to highlight that during this time.
Yes, that's very good. I mean, my two questions, one was about age. So how do we include children in some of this? And then the other one on funding, which is going to be a longer term discussion, but we will certainly include you in that and welcome your involvement with us. That'd be great. Senator Hardy.
Thank you. Commissioner, you said that you had a request in the BAA in the budget adjustment or in the actual budget? Just to be.
Sure, it's in our BAA under our HCBS FMAP proposal.
Okay, I don't remember hearing that yesterday when we went over the BAA.
It wasn't clear. You're right, Senator.
Yeah, did it get included in the House version of the budget adjustment?
I can follow up on that unless Allison, you have an answer off the top of your head.
Yeah, I mean, you have me thinking. I thought we did FY23 budget in that BAA.
Right, earlier this week we did FY23. BAA was a couple of weeks ago, and I don't know if we presented that to this particular committee.
No, you didn't. And
if it's
so
FY23, it would be in the big bill.
It'll be in the big bill, and
Yeah.
frankly, it probably belongs in the big bill.
Yeah.
At this point. Senator Cummings, you wanted to say something? Okay.
Can I ask the commissioner another question?
Sure.
So I would appreciate if you all could come back and give us more detailed on the actual language in the bill. I have some questions about the language and how it all works together, but and specifically when it relates to the department, I don't remember which witness said this, maybe Ms. Melton, but about reporting to DMH, the statistics and et cetera. And so I'm curious about what reporting requirements are already in place. And if you would, maybe it was Ms. Vandenberg, or if there were some additional ones or fewer ones or whatever you would recommend in that, because it would be really great to know if we put this all into place, the efficacy and what, how many people are using it and what the bang for the buck, for lack of a better term, is on the programming. So
I believe that Wilda has given you a copy of our grant, or the part of our grant that's not the boilerplate part. And I think that outlines very clearly what reporting DMH expects. That it's written into our grant. So that's all done. That's all outlined.
Yeah.
And I'm just wondering if the bill is proposing the similar structure to what you already have for Alyssum, and if that would be the same for all of the respite centers.
If I may, Senator Lyons, respond to that briefly.
Sure.
Yes, so Senator Hardy, the current bill does have a provision and some accountability provisions in there, and it actually asked the Department of Mental Health to come up with those standards, which we assume would be the same ones that the department has already come up with that Alyssum adheres to. So it is in the bill.
Okay, great, thank you.
Okay, yes, good questions. This is the beginning, obviously, of our discussion. And it's broader than the bills that we've looked at. We're trying to sort out how we can build and fill the gaps in our infrastructure and improve what we have in terms of linkages between and among all the different working groups. It gets extremely frustrating. The more you get involved, the more I've gotten involved, the more I understand that we need to have some leadership and coordination overall. So for me, that belongs rightfully in the Department of Mental Health, working alongside of folks who understand the system and what's out there. So we're gonna try and get to closure. My other concern that I think we all need to think about is our children. And how can we include kids in this kind of support system? We heard from Lynn Coda today, and she's just one person. We will, as we go forward, we may want to hear from more pediatricians, but I think the Children's Hospital at UVMMC has had significant experience with what's going on with kids in the ED and how they are handled. And what we can do there. So further discussion. And I just want to say thank you to each one of you for taking the time to be so thoughtful and to bring us such a really a good report, in-depth information. And it just opens up a conversation for us as we look at the bills going forward. So thank you. We're gonna call it a day, and we'll see everyone, committee members, tomorrow, and hopefully we'll see some of you folks in at other meetings. So thank you.
Thank you, Senator Lyons. And